Good afternoon, everyone. I'm Dr. Siddhartha. First, I would like to thank the organizing committee for providing us this opportunity to present our research papers. My sincere greetings to the respected dignitaries. Before presenting a paper, I would like to reveal a bitter truth that many of us are at risk of being dragged below the poverty line. You may all wonder why I'm saying this, because a World Health Organization report termed Indian Health System Review has stated that every year 55 million Indians are being dragged below the poverty line. So we are also at the risk of it. Will be very curious to find out who is the culprit is. And it is the out-of-pocket health expenditure and its severe form, the catastrophic health expenditure, which is responsible for this catastrophe, that the dragging 55 million Indians below poverty line every year. Government of India has been taking various efforts to alleviate poverty, but this single factor, out-of-pocket expenditure, is reversing all the efforts. It is a high time to have an integrated and holistic approach to tackle the monster of out-of-pocket expenditure. The title is Addressing Out-of-Pocket Expenditure through Business Process Innovations. I focus mainly on the rural areas of Viluppuram and Kallakurichi districts based on some case studies. The International Monetary Fund has released the World Economic Outlook, where it stated that India is the fastest growing major economy. Despite the economic growth potential, the inequity in the distribution of resources and opportunities is well acknowledged, particularly in the health sector. The right to health is an integral part of the Article 25 of the Universal Declaration of Human Rights and Article 21 of the Indian Constitution. However, for a developing country like India, this out-of-pocket expenditure is posing a major obstacle in restricting the accessibility and affordability to healthcare. So the poverty and out-of-pocket expenditure have a bidirectional cause-effect relationship with each other, reinforcing them in a vicious cycle manner. In this regard, the policy interventions like Ayushman Bharat, Jan Arogya Yojana and state-specific insurance schemes have some functional and structural issues which will be dealt in the later part of the presentation. In this regard, the Right to Healthcare Act, enacted by the state of Rajasthan, tried to address this out-of-pocket expenditure by making the right to healthcare as an entitlement to all the residents of Rajasthan. However, it also encumbers the private healthcare sector by shifting the responsibility to them, and this has led to a huge statewide protest and near total disruption of the healthcare delivery services. So the revamping of healthcare through business process innovation has a huge potential to address this out-of-pocket health expenditure. Based on our extensive comprehensive literature, we found that there is a stark urban-rural divide in terms of out-of-pocket expenditure, in which out-of-pocket expenditure is affecting the rural population comparatively more than the urban population. And the proportion of catastrophic expenditure has increased drastically in the last 2 decades. This is a brief overview of the magnitude of the problem. Like, the 18% of the households incur catastrophic expenditure every year. As far as the state of Tamil Nadu is concerned, which is well in terms of healthcare systems, but still the Niti Aayog report states that 39% of the households are heavily burdened due to the out-of-pocket expenditure. The research question was to analyze the role of government incentivized and government-driven business process innovations in alleviating out-of-pocket expenditure, and what could be the potential impacts of government incentivized business process innovations in terms of reducing the out-of-pocket expenditure. The broad research objectives are to analyze the current out-of-pocket expenditure in terms of the trends and patterns. Second one, to identify the prospects of business process innovations in addressing the out-of-pocket expenditure, and to analyze the impact and how it's going to impact the healthcare delivery in terms of accessibility, affordability, efficiency and quality. Next, to recommend some policy intervention based on some evidence-based recommendations, and finally to contribute to a academic discourse, because this topic of business process innovation is in healthcare has a paucity of the scholarly articles and research. We followed a mixed methodology, employing both qualitative and quantitative. The primary research was conducted in the months of October-November 2022 in Viluppuram and Kallakurichi districts of Tamil Nadu. The reason why these districts are chosen was the demographic profile in terms of sex ratio and urban-rural composition was somewhat similar to that of Tamil Nadu. The study focused on out-of-pocket expenditure in terms of how many people are availing microfinance institution loans to meet their out-of-pocket expenditure needs. So the sample size is about 60 female head of households from 6 villages. These are the villages. These villages are selected based on simple random sampling method, and the sample population was chosen based on snowball sampling method, because to find out who are all the people who are, availed loans from the microfinance institution to meet their healthcare needs. The qualitative research, we initially had a discussion with the residents of those rural areas with the help of an NGO. Then we gained some insights about their perception on healthcare out-of-pocket expenditure. Based on that, we arrived at a structured questionnaire, and through that structured questionnaire, we gained some responses from the 10 female head of households from each village, and the data were collected and analyzed using Stata and Excel. For our second research on out-of-pocket expenditure, we relied on data sources like the government reports of Ministry of Health and Family Welfare, the international reports of World Health Organization in terms of World Health Statistics, Indian Health System reviews, academic journals, systematic reviews, and the reports of think tanks like National Health Systems Resource Center. The data analysis tools we used are the same, the Excel and Stata. So let's begin with what is out-of-pocket expenditure. According to World Bank, it is defined as a direct payment made by the households to the health practitioners and the suppliers of pharmaceuticals and the services and the goods and services that are intended to restore and improve healthcare, which are not covered by the usual health insurance scheme. And catastrophic health expenditure refers to the health expenditure which is exceeding 25% of the total annual household expenditure. These are some basic terminologies. The main focus is on the government health expenditure, which constitutes spending under all schemes funded by the union, state and local governments, and the out-of-pocket expenditure, which is been defined earlier. So this is the broad overview of health expenditure in India. The total health expenditure is, according to the National Health Estimates, Account Estimates 2019 to 20, the healthcare expenditure, total health expenditure is about 3.3% of the GDP, and the current health expenditure, that is the day-to-day costs and operational costs, it contributes to 90.5%, and the capital health expenditure, which results in the healthcare infrastructure creation, contributes to just 9.5%. This is a thing to ponder upon, and the government expenditure is 41.4% of the total health expenditure, and out-of-pocket expenditure is 47.1%. See, we can see that which is this government expenditure is 6% less than the out-of-pocket expenditure. We can see that from 2013 to 2019-20, we can see there is a gradual increase in the government health expenditure and gradual reduction in the out-of-pocket expenditure. But still, the out-of-pocket expenditure is more than the government expenditure. This is the current health expenditure in terms of healthcare financing. We can see that the out-of-pocket expenditure contributes to 52% of the current health expenditure, and the state contributes to 20%, union 12%, and private insurance 6.6%. And in terms of healthcare providers, the private hospitals contribute to 28%, pharmacy contribute to 22%, government hospitals 16%, and preventive care 5.6%. These are the major contributors. Coming to the importance of private sector in Indian healthcare system delivery, according to the National Family Health Survey 3, the private medical sector contributes to the 70% of the medical needs in the urban areas and 63% of the medical needs of the households in rural areas. And private sector also contributes to more than 70% of the outpatient care and 56% of the inpatient care. This significant role is being played by the private sector in terms of healthcare delivery in India. As far as Tamil Nadu is concerned, the government expenditure on health as a part of the GSDP is just 0.9%. However, the government health expenditure in terms of general government expenditure, that is the portion of government expenditure on healthcare out of the total expenditure, it's about 6.6%. According to a report published by the Niti Aayog, paying out of one's own pocket, this is the name of the report, 39% of the households in Tamil Nadu are heavily burdened financially because of the out-of-pocket expenditure. The primary research we conducted, we surveyed 10 people from each village. These are the number of people who availed microfinance, and these are the people who availed microfinance because to meet their healthcare needs. It is observed that more than 40% of the people avail microfinance for their healthcare expenditure. Next, data regarding the disease, whether it is acute or chronic, it is seen that the reason for out-of-pocket expenditure, the 77% is because of the acute cases like fever, diarrhea, and the chronic cases like diabetes, hypertension contributes to 23%. And in terms of public-private, the people who availed these health services, 69% of them avail from private and 31% from the public. Existing policy interventions are the Ayushman Bharat Jan Arogya Yojana and Tamil Nadu's comprehensive health insurance schemes. They provide a coverage of 5 lakh rupees per family per year. However, there are some issues like coverage issues that the eligibility income criteria fairly covers the lower income group. The higher income group will be covered by the private insurance. The problem is with the lower middle income group, who are termed as the missing middle, because they are neither covered by the government public health insurance schemes nor by the private health insurance schemes. So they are at a very risk of the catastrophic health expenditure. Second one is the geographic disparity with respect to the urban-rural divide in terms of empaneled hospital availability. Jan Arogya Yojana is mainly concerned with the second and tertiary care needs, and the primary care is totally neglected. Health being a state subject in the 7th schedule, many states have their own state-specific policies to address to provide health insurance schemes, but the issue is with the states and center to coordinate and streamline and harmonize the both schemes, not taking into consideration of other opportunity costs like the pharmacies, the transportation costs, the loss of wages for the caregivers. These are not covered by the health insurance schemes, and issues in availing, and these are some technical issues like getting included in the ration card names for availing these benefits. These are some of the issues. Coming to the business process innovation, this business process innovation refers to the different types of methodologies and strategies to increase the efficiency of the process and effectiveness of the outcomes. This business process innovations in healthcare has the potential to increase the affordability and accessibility of the healthcare. Some of the challenges in this are these BPA are restricted to few philanthropic organizations. There is no incentive mechanism, absence of research, and lack of holistic policy interventions. Some of the BPAs that we were looked, or the first one is the cross subsidization. It is like providing a similar kind of surgical services, medical services to affluent people with some higher price and to underprivileged people at a very subsidized price. Take for example the Aravind Eye Hospital model. They may differ in the accessory services, but the essential services will be of same quality to both the affluent as well as the underprivileged. Second one is the app-based repository of information displaying the real-time information regarding the beds availability that are provided through the cross-subsidization strategy. Then employing or involving cooperatives in the development of model mini clinics to address the urban-rural divide. This BPA is being supported by the Ayushman Shahakar Yojana of Government of India. Then there is an initiative called Healthcare at Your Doorsteps model for non-communicable diseases like diabetes, hypertension, implemented in Makkal Thedi Maruthuvam in the state of Tamil Nadu. Then integrating Jan Aushadhi shops with a single doctor clinics through incentivization. So these are the whole summary of the expected benefits. They will reduce the financial burden on the public exchequer. They will address the geographic disparities. They will reduce the out-of-pocket expenditure associated with the transportation and pharmacies. These are the benefits of business process innovations in healthcare. Thank you.
Jyothi has highlighted some very important sort of elements of Indian healthcare, which is one is out-of-pocket expenditures, one is about catastrophic health expenditures, and he's also suggesting how business process sort of innovations can possibly bridge in. Okay, so I'd like to open the floor at this point, and if there are people with questions, suggestions.